You're listening to This Week in Cardiology from theheart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.
You can now access the latest in medical news on your Amazon Alexa-enabled device. Join me, Perry Wilson, every weekday morning for Medscape Medical Minute, where I highlight the top medical stories of the day. To add Medscape Medical Minute to your flash briefing, search for Medscape Medical Minute on Amazon and click Enable. Or open the Amazon Alexa app, go to Skills, search for Medscape Medical Minute, and click Enable. Then say, Alexa, what's the news? Or Alexa, what's my flash briefing? I hope you'll join us.
Hi everyone, this is John Mandrola from theheart.org, Medscape Cardiology, and this is This Week in Cardiology for April 28th, 2023. This week, cardiac device infections, observational studies, RCTs, and our ways of knowing in medicine. First, I'm recording from San Antonio, Texas, thanks to Dr. Anand Prasad and Shuta Bansal from the University of Texas for the invitation to spread the message of medical conservatism and critical appraisal at the 6th Annual Cardio-Renal Connections Conference here. My friends, this is a bit of a special podcast. I normally cover 4 or 5 topics, but today I'm going to focus heavily on 2 topics. Next week and subsequent weeks on TWIC, I'll return to the typical format. Just let me know what you think. So, 2 studies and 1 editorial published this month address the issue of cardiac device infections. Device infections are another increasing problem of modernity. That is, because people live longer with more comorbidity, there's more time to require a pacemaker because longer life equals more time to get age-related conduction system disease. Also, CRT and ICDs have become valuable additions in the treatment of heart failure. And now, in 2023, one of the most common causes of CIED infections, device infections, are generator changes, and I'll speak more on that later. The bottom line is, we're putting in more devices, so we're going to have more infections. So one study, published in JAMA Cardiology, was a secondary analysis of the Canadian PADIT trial, originally published in 2018. PADIT compared different antibiotic regimens in 19,000 patients and actually found no significant difference whether you used incremental antibiotics or more conventional antibiotics around the procedure. The purpose of this observational study, which used data from the RCT, was to evaluate the association of the extent of timing of the CIED infection with mortality. Think early versus later device infections. Now, the more interesting paper, in my opinion, came from Jack, and it was an observational analysis of device infections and lead extraction. Its findings have generated provocative headlines and an editorial that actually implies doctors are not doing things right. So first, before I talk about either of these studies, let's just do a couple sentences on background on device infections. While I love cardiac devices because pacing for heart block or heart failure is one of the purest things we do, I mean pure in that sick patients are asking for our help and we have proven therapies that extend and enhance life. Yet, even when we act on the strongest grounds, complications can occur, and one of the most feared complications of a cardiac device is bacterial infection. And when it happens right after placing a new device, the decision is pretty easy. You just explant the system and treat with antibiotics, and you try again after the infection is cleared. But a lot of bacterial infections on devices occur late. A cellulitis can cause transient bacteremia 2 years after the device is placed. Then that bacterium can attach to the leads, and infection on leads can then lead to cardiac valve disease, endocarditis, and Staph aureus is obviously the worst of the pathogens. Once this process happens, we have a super serious problem because pacing or ICD leads that have been implanted for years cannot easily just be pulled out, right? The body reacts to foreign material by forming scar around the leads. This causes the leads to attach to anatomic structures like the SVC, atrial tricuspid valve, or RV. Now, thankfully, iterative technology from industry has advanced the field of transvenous lead extraction. Yet, lead extraction is not for the meek of heart. It is hard, very hard. It requires extensive training, a backup surgical team, and wait for it, experience, lots of experience. You can't expect to master lead extraction at an industry-sponsored weekend course. Master extractors are made over years. And here's the problem. Infection of leads requiring extraction is uncommon, right? I mean, it's bad, but it's uncommon. So it's hard to build up experience. American healthcare makes it even harder to get this experience because too often doctors fear missing out. And instead of designating 1 or 2 doctors in a system to be the extractors, hospitals may have many low-volume operators instead of 1 or 2 high-volume operators. And of course, industry too supports the idea of more, not less operators. All right, with that background, let's go to the paper. JAMA Cardiology published a timing of infection paper. The authors took the nearly 20,000 patients in the PADIT, P-A-D-I-T trial and focused on the 177 patients who had had infections. And they broke these down into 4 categories, 2 groups of 2, early versus late infection, that's less than 3 months versus 3 to 12 months, and localized versus systemic infections. First finding is that the cumulative incidence of infection was very low, 0.6%, then 0.7% and 0.9% within 3, 6, and 12 months. But the absolute rate of infection was highest in the first 3 months. It was 0.21% per month, and it reduced significantly thereafter. That's not a surprising finding. Finding 2, any infection doubled the rate of mortality versus no infection. That too is not surprising. But here are some interesting findings. The third finding was that early localized, like a pocket infection, did not increase in mortality, but early systemic, say blood infection, had a big increase in mortality, 3x. Surprisingly, the fourth finding was that late local infection, so a pocket infection 6 months later, had a 3.5 times risk of death versus no infection, and a late systemic infection, so a bacterial infection in the blood, a year later, that was a 9x risk of death versus no infection. The authors concluded that while device infections are most common early, less than 3 months, delayed infections, even localized infections within the first year, are associated with substantial risk. They conclude that early detection and treatment of device infections may be important. They wonder about the common policy of checking the incision at 1 week and then not seeing the patient again for 12 months. I say good on the authors. They make relevant observations. They do not make causal conclusions, and they suggest considering a slightly different follow-up of patients after pacemakers. First author here is Wei Jen Han from the University of British Columbia. Now, let's contrast this with the JACC paper. The JACC paper was a survey of the National Readmissions Database of 25,000 admissions for patients with device infections and endocarditis between 2016 and 2019, and they used ICD-10 codes. The goals of the study were to document use and trends of lead extraction over a 3-year period, also to find predictors of the use of lead extraction, and to describe the association of lead extraction and all-cause death. Again, patients with endocarditis and device infection. Now, the National Readmissions Database is a database of de-identified hospital inpatient discharges and readmissions, and it allows for national estimates of hospital utilization. Now, I'm not going to object to some parts of this study, but others I am going to have a strong objection to. First, the rate of lead extraction was only 11% in endocarditis. That's interesting in that 89% of patients with devices and endocarditis did not get lead extraction. It is so low that it makes me wonder about the validity of this data. Now, the second non-controversial finding was that the rate of lead extraction use increased over the 3-year period, and procedural complications were around 3%. Now, the predictors of having lead extraction also are not very surprising, right? Staph aureus was the strongest predictor. Having dementia, cerebral vascular disease, kidney disease, drug use were all predictors of not having extraction. Again, these findings are good uses of observational data, right? Science tells us what we can do, trials tell us what we should do, and registries tell us what we are doing. The problem comes in the temptation to compare patients who had or didn't have lead extraction. Of course, these are non-random comparisons in which a clinician somewhere in some hospital made a decision to extract this leads or to not extract. Table 1, patient characteristics. Always go to Table 1. Here we see massive differences in the two groups. Patients who got lead extraction are younger, dominated more by males, more likely to have defibrillators. Patients who did not undergo lead extraction had more cerebral vascular disease, dementia, and kidney disease. So you know what comes next. The authors attempt matching. They used propensity matching. But as I have said many times, this cannot easily match randomization, especially given the patient variation, hospital variation, and likely different levels of lead extraction expertise. They found that the index mortality was significantly lower among patients managed with lead extraction, 6 versus 9.5%. The p-value is really small. Of course, it's better, right? Healthier patients got lead extraction. After adjustment, the lead extraction was still independently associated with significantly lower odds of mortality. Here it was a 53% reduction. Of course it was. The authors concluded that the use of lead extraction among patients with devices and endocarditis was low, even in the presence of low rates of procedural complications. Lead extraction was associated with a significantly lower mortality, and they write, barriers to lead extraction for patients with devices and endocarditis require investigations. They further write, quote, to our knowledge, our study is the largest to date to demonstrate reduction in mortality associated with lead extraction management of patients with devices and infective endocarditis. Now, recall, if your sample is biased, it doesn't matter if you have 1 million patients, right? Bias times bias is still bias. The editorialist also leaped to causal language. Quote, the messages from the current and prior reports on the issue of device infections are clear. 1, device infections increase mortality. 2, extractions reduce mortality. Notice the action verbs. 3, extraction-related complications and mortality are low at experienced centers. And they go on to write, it is imperative for healthcare providers managing patients with devices to recognize device-related infections and make early referrals for extraction. So my comments on this whole topic, I agree totally that ICD and pacemaker infections, especially those that cause bacteremia, are terrible, terrible. Having seen these consequences is one of the main reasons I am conservative about who should get an implant. In my opinion, doctors discount the seriousness of having a device with leads in their heart. I also believe strongly in meticulously evaluating the harm-benefit calculus in every generator change. Generator changes are a major source of infection, and many of these can sometimes be avoided with good doctoring, including frank discussions with patients and families. If you don't open an incision to change a device, you don't incur the risk of infection. I also believe there's surely some degree of undertreatment of device infections, especially in rural settings that have limited access to extraction centers of excellence. But, my friends, we can raise awareness, educate, improve access without using flawed studies and flawed causal conclusions like those in this paper. The limitations of this analysis are many, right? First of all, the National Readmissions Database is problematic. The authors tell us in their own manuscript that the National Readmissions Database only includes information from 22 of 50 states in the United States. What about the other states? The National Readmissions Database is derived from ICD codes, which are also limited. Missing data is likely. Both of these are almost disqualifying in and of themselves, but mostly, though, non-random comparisons of two groups, those who got lead extraction versus those who do not, is a deeply flawed analytic method. Propensity matching from this sort of data is extremely unlikely to approximate randomization, and the 11% rate of lead extraction of patients with endocarditis should have indicated that there was probably something amiss with this data in the first place. All right, next topic, real-world evidence versus trial evidence. Speaking of causal inference, JAMA has published an incredibly important paper, one of the most important of this year, I think. This was from a group of expert epidemiologists that are part of the RCT Duplicate Initiative. Their project, supported by the FDA, aims to better understand real-world evidence studies. Specifically, these authors tried to emulate an RCT using insurance databases. They did this by identifying and implementing observational analogs of RCT design. We can abbreviate these analogs PICOT, right? Population, say heart failure patients, intervention, say the drug, comparator, placebo or standard of care, outcomes, mortality, and time frame. They then applied confounding adjustments to the non-random comparisons of these patients. Much like an RCT does, these calculations then output an effect size, usually an odds ratio. The question, of course, is how good are these estimates? So, in this paper, their final and ultimate comparison, they compared the outcomes of the emulated trials to actual RCTs that have been done. Now, you can see the massive implications of such research, right? I see two right off the bat. One is that we know that RCTs are the best way to make causal inference of a therapy and an outcome. Randomization balances confounding variables, both known and unknown. Both groups and RCTs also start at the same time and outcomes are adjudicated. But, even when the internal validity of an RCT is impeccable, the problem comes in applying that evidence outside the confines of a trial to your patient in the clinic. So the first implication of this research is to test the external validity of the trial results. Treatment A may work in a trial, but how does it work outside the trial in the real world? So the second implication of this emulation work is that RCTs are hard to do. They're expensive. Some things in medicine are not amenable to an RCT. So if we could extract data from insurance databases, for instance, and emulate a trial, that might help inform care, be better than expert opinion maybe. So here's what the researchers did. They selected 30 already completed RCTs and 2 ongoing trials. These were the trials they were going to try and emulate from real-world data. Now, the selection is important. The authors emphasize that these were highly selected trials. There had to be similar study parameters in the insurance databases, and the emulation had to be feasible in that the PICOT, population, intervention, comparator, outcome, and time frame were all available in the database. Many, but not all trials were cardiac in the study. The emulation stemmed from 2 insurance databases and Medicare. Now, the authors have previously outlined how they did the emulation. Suffice to say, this is about 100 times more extensive than propensity matching 2 groups of patients. So the first thing they do is they extract the study parameters, the PICOT. They then check for feasibility, such as the power and the balance of the groups. And if it wasn't feasible to emulate, they didn't even try. They then documented the primary and secondary analysis, and they included looking at control outcomes. And of course, that's important because you'd want the control outcomes of your emulation to be similar to that in the trial. They then registered the protocol at clinicaltrials.gov, and then they did the analysis and compared the results of the real-world trial emulation to the actual RCT. So you imagine in your head pairs, right? One part of the pair was the effect size and confidence interval from the RCT. The other pair was the effect size and confidence interval from the emulation. And they then assessed the agreement in 4 different ways. The first was they took all the studies together and did a correlation. And then the pairs were assessed for full statistical significant agreement, and that's if the estimates of both, including the confidence intervals, were on the same side of the null, so positive or negative. The second way they assessed how well they agreed was an estimate agreement. Did the real-world emulation estimate fall within the 95% confidence interval of the trial? And the third way they assessed it was just a standardized difference agreement, and that was, did the real-world emulation fall within 2 standard deviations of the trial? And here are the results. The overall agreement had a correlation of 0.82, so pretty good. 75%, 3/4 of the real-world evidence emulations met statistical significance. Only 56, however, met full statistical agreement. 2/3, 66% of the emulations met estimate agreements, and 75% of the real-world emulations fell within 2 standard deviations of the trial. Now, this is pretty good, isn't it? Well, then the authors did a post hoc analysis wherein they looked at the pairs that had closer emulation to the trial. 16 of the 32 trials had closer emulations. In other words, the data in the database more closely approximated the data in the trial, and here they found that 94% of emulations met statistical significance and 88% met estimate agreements and standardized difference agreement. However, the flip side of these good results were that in the 16 emulations that were not as close to the trial, the concordance was quite weak, where only 50% of the pairs were similar. Okay, so there were some barriers, right? 10 trials used placebo, but of course there are no active placebos in the real world evidence, so they emulated a placebo with, quote, new use of an active comparator that was strongly expected to have no effect. Other problems with the emulation included trials that did dose titration during the follow-up, trials that had run-in windows, drugs that were initiated into hospitals, delayed effects over longer follow-up, and of course confounding. All of these are barriers to trial emulations. So my comments. Now, I realize that some of this borders on the technical, but the issue of how we know things and with what certainty has to be one of the most important things in all of medicine, perhaps in all of science. This is huge. Also, remember, healthcare data is ubiquitous. We are putting in healthcare data every day in clinic, right? Especially now with the electronic health records. And trials, randomized controlled trials, are expensive and hard to do. So the idea of being able to harness all of the data that we put in to increase our knowledge, that's an enticing idea. In sum, I find the results of this report nuanced but sobering. And here's how I think about it. I think that this is a best case scenario. These are clearly top people in causal inference. Their methods are rigorous, well-documented, pre-registered, and they only attempted trial emulations when it was feasible. They carefully selected trials to compare to. They note that many trials in medicine simply cannot be emulated with real-world evidence because the data isn't similar enough. And yet, in this best-case scenario, full emulation of a randomized controlled trial was modest. Let's say it's about 75%. That's good, but the flip side is that 1 in 4 carefully done trial emulations from top people using rigorous methods did not emulate an RCT. And one example in cardiology stands out. Get this. Paradigm HF. Paradigm HF was a trial they chose to emulate in this paper. Recall that Paradigm HF was ARNI, sacubitril valsartan, versus enalapril in patients with heart failure with reduced ejection fraction. And you all know the outcome, right? Sacubitril valsartan was much better, and now the drug is established as first-line therapy. Of course, there's controversy surrounding this approval because FDA often requires 2 trials, and there was the issue of enalapril being maybe a soft comparator. But get this, the real-world emulation came up with an odds ratio of 1.0, no effect. So if you look favorably on the results of this JAMA paper, you're going to have to deal with the fact that real-world evidence did not duplicate Paradigm HF. Now, let's pause for a moment and consider why Paradigm HF didn't emulate or duplicate. Now, one way to think about this is that the trial was correct and the real-world emulation is wrong. And purists will argue this way. I suspect some of my heart failure colleagues would say, come on, Mandrola, the RCT trumps any trial emulation. And maybe that's true. And in support of that would be the overall results of the paper, which found that full statistical agreement was better than a coin toss, but not much better. Now, another possibility to explain the discordance was that the Paradigm HF trial was flawed and the null real-world effect is actually correct. Now, here the argument would be, as the editorialists suggest, that RCT evidence is just one component of causation. To confirm causal effects in patients, you'd like confirmation or external validity with real-world data. So the discordant effects suggest that real-world trial emulation of sacubitril valsartan does not complete what the editorialist calls the complete causal mechanism. In other words, if sacubitril valsartan was truly beneficial, it would be positive in both the trial and the real-world evidence. Now, here's the core problem with these two ideas is I don't know which one to believe. Is the real-world emulation that finds no effect correct, or is the trial correct? Or perhaps both are correct and the trial enrolled such special patients under such special circumstances that it isn't duplicated in the real world. Now, I was struck by this comment in the editorial. Quote, after all, emulation of a single trial requires hundreds of subjective decisions. And of course, so does doing an RCT. So in the end, I'm left with Dr. David Cohen's conclusion on observational studies. That is, he writes, Some observational studies are correct, I just don't know which ones. Yet another caveat. It is absolutely true that many RCTs do not replicate or duplicate. Rheumatologist Mike Putnam on Twitter cited 2 RCTs of a drug for lupus that were almost identical, same primary endpoint, same acronym, similar methods, published the same day in The Lancet. One was significant and one no. And I can cite a JAMA paper from a Stanford group that finds that reanalysis of trials, often by the same authors, fails to replicate in 1 and 3 times. So to me, this means that when there are small effect sizes, which represents most of modern-day cardiology, we should have low confidence in benefits. And my final statement here is to the notion that this is sort of good, almost matching of real-world data and trials shows that we could then use this technique for situations where there is no RCT data or a question that's not amenable to RCTs. But I strongly, strongly oppose this idea. And here is why. Because here are experts using the highest level techniques, and while they matched trials often, they were correct, for instance, they were mismatched enough to be worrisome. And to make matters worse, if there was no RCT data in an area, how would we even know what to think about the emulation? Was it like those that matched perfectly, or was it like the Paradigm HF emulation? And the thing is being wrong about causation can lead to disastrous consequences. The asymmetry is significant. The downside risk is enormous, right? Doctors can be easily swayed. Therapeutic fashions, once established, are hard to break. I mean, think about antiarrhythmic drugs after MI, hormone replacement therapy for cardiovascular protection in women. I would also ask my colleagues to consider what if they are wrong about left atrial appendage occlusion. We've done 100,000 cases in the absence of RCT level data. Finally, I'm almost done with this. Consider this scenario. Imagine an observational study that is now called an emulation study, and it finds a benefit for a costly drug or device. Now, editorialists, key opinion leaders, professional societies, along with the huge marketing forces, could then be put into motion because this was no readmissions database study with propensity matching. This was a trial emulation. But in the absence of RCT evidence, we would have no idea if the emulation study was correct, as in the case of the Paradigm HF example. So my thoughts on knowledge remain unchanged. There is a heck of a lot more equipoise than we think. We need to randomize more often. Trial emulation efforts should continue because this is a great start, but I would place a lot more emphasis on creating networks wherein trials are more feasible and easier to do. Please do read this paper. I've read it like 5 times. Let me know what you think. We need to have more conversations about this paper. And finally, to close, another feature you might like, which is related to the translation of evidence in the clinic, is a discussion I had with my friend Andrew Foy about applying trial results to patients. We had this discussion at the American College of Cardiology meeting. It's up on the heart.org Medscape cardiology site now. One of Andrew's areas of research involves the way in which multi-morbidity interacts with treatment effects. The novel idea he and his group has is to create a comorbidity score using the Carlson Comorbidity Index. Now, the Carlson Comorbidity, or CCL, is a way to quantify total morbidity. This is different from the typical subgroup analysis that you see in papers. These graphs in the papers consider the effect of one thing, say diabetes or CKD or whichever, but it's hard to take those one categories and apply them to patients in the clinic. You can listen to our conversation or you can read the transcript. And I think this issue of multi-morbidity is going to be increasingly important as our patients grow older and live longer with more comorbid conditions. So that's it for this week in cardiology. As always, I'm grateful that you listened. Thank you. And remember, if you like this podcast, please take the time to give us a rating, write us a review. These little things go a long way, help others find us. Until next week, this is John Mandrola from the heart.org Medscape Cardiology.
You're listening to This Week in Cardiology from the heart.org Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.